Welcome and thank you for joining us this afternoon. My name is Kathy Turin and I am a consumer health librarian at East Brunswick Public Library. This Lunch and Learn series is sponsored by Princeton Radiation Oncology, Regional Cancer Care Associates Central Jersey Division, Rutgers Robert Wood Johnson Medical School, Digestive Disease Center of New Jersey, and the Libraries Just for the Health of It initiative to promote community health and wellness. Before I turn things over to today's speakers, I would like to ask you to please mute your microphone and turn off your video. If you have any questions, please type them into the chat box. Our presenters will answer questions at the end of the talk. Please note, the doctors presenting will not be able to offer personal medical advice to attendees during this program. Please be aware that this talk is being recorded and will be posted online at the library's YouTube page at ebpl.org/YouTube. And without further ado, I shall turn things over to the doctors.
Hi, and good afternoon. Thank you so much for being here. We go to the next slide, I think. The reason we started doing these conferences about 2 months ago was that there was a concern during COVID about delays in cancer care. And we wanted to reach out and start to build relationships to try to make people understand that it was possible to get cancer care during this time. There are steps which we'll discuss today to get that done safely and appropriately, but we were quite concerned about delays that we were starting to see. And that's one reason we started this series. And then the other reason is that we realized that there's an opportunity with everyone now doing more of these sort of Zoom conferences to start to build an educational base, to work together as a community, and kind of learn from each other as we were going through this. So thank you all for being here today. We're very, very excited, to have you. We have three really great speakers with me here today. I'm thrilled that they've given the time for this, and it just shows the strength of cancer care that we have right here, in our community. Each will have an opportunity to speak, but just briefly, Dr. Merkel, who's a gastroenterologist, based out of East Brunswick, with one of the dominant GI group in the area. Ira's it's a skilled gastroenterologist with extensive experience both in this disease and in gastroenterology, and has been a true friend and in the community for many years. Dr. Josh Pepek, who is with Princeton Radiation Oncology. As you may know, Princeton Radiation Oncology recently merged with RCCA, with the company that I work with. Princeton Radiation Oncology has been the dominant private practice radiation oncology group in the area, with multiple offices around the region, and including the ProCure Proton Beam Center out in Somerset. And Dr. Nell Maloney Patel, who is colorectal surgeon at Rutgers Medical School, Robert Johnson University Hospital. Nell is a gifted surgeon both in this area and in colorectal disease in general. She's also a key leader at Rutgers Medical School, which she runs the surgical residency program. And I consider her a true friend both to the community and to myself, frankly. And we're just thrilled to have them all here today. And Dr. Chris, medical oncologist with Regional Cancer Care Associates. RCCA, as you probably know, is the dominant private practice oncology group in the state of New Jersey, the second largest physician-owned private practice oncology group in the United States. So next slide, please. So the reason we want to talk about colon cancer today is, first of all, that it is a disease that is curable. And that can be done by prevention. It can be done by early detection. It can be done by treatment, and that can happen even during COVID. It is a common illness. Around 1 in 20 individuals will have it. Over 53,000 people will die of it this year. And as I note in the comment there, the most depressing words that oncologists ever hears is, "I've never had a colonoscopy." So there's a lot to talk about as far as therapy. This is a disease that we are very successful in treating, but is very important. Next slide, please. So I'm not going to go through too much of these facts. I know that Dr. Merkel wants to review them and will in detail, but just a couple of quick points. This is a disease that has variable density around the United States, but is an increased density in our area. It is a disease for which prevention can make a significant impact. And it is the obvious things. It is less alcohol. It is less red meat and less fat in the diet. It is decreasing obesity. It is increasing exercise. It is increasing fiber. All those basic things make significant difference about the occurrence of colon cancer. There's also the possibility that aspirin may decrease the risk. That's pretty clear. The problem, aspirin is not a simple drug, so we shouldn't all start taking aspirin, but that's a conversation to have with primary doctors. But the real key point at the bottom, and then I will turn this over to Dr. Merkel, is that 25% of colon cancer cases are found late. And when we find them early, 90% of people are alive at 5 years. But when we find them late, only 14%. And that is indeed a tragedy. And that being as a start, I will turn this over to Dr. Ira Merkel. Ira.
Well, thank you, Jim. I appreciate those kind words and the invitation to speak about this topic. It's interesting because yesterday we had a webinar in our specialty society talking about this. So obviously this is a hot topic. Next slide, please. So I like this cartoon, and we talk about health maintenance, and there are a lot of people who bury their heads in the sand and say, well, if I don't look for anything, we won't find anything, so I must be healthy. So obviously that's not the case. Next slide. So what are the numbers we're looking at when we come to colon cancer? Well, it's the fourth most commonly diagnosed cancer in the United States. That gives you a sense of the numbers that we see per year. It's the second leading cause of cancer death annually. There's a decline in the incidence. That means the rate of newly diagnosed cases in patients over the age of 50, especially over the age of 65, and that's probably related to more screening. However, we're seeing an increased incidence in adults younger than 53. In fact, probably between 45 and 53 has been a rapid rise. You could sort of see 51% have increased during this time interval, even though the overall incidence is low. And we still really are not quite sure why that's the case. Next slide. So there's a lot of terms bandied around in terms of what people hear, and a lot of this confusion has to do with insurance and coverage, but let's sort of make sure we all define what we're talking about. So we're talking about screening versus surveillance versus diagnostic. So a screening evaluation is an asymptomatic patient. There's no prior history of colon cancer or precancerous lesions. A surveillance procedure is the interval use of a colonoscopy in a patient with a history of colorectal cancer, precancerous polyps or lesions, or somebody who may have inflammatory bowel disease like Crohn's or ulcerative colitis. And a diagnostic test is an investigation of symptoms, such as rectal bleeding, a positive screening test, such as the FIT or the multi-targeted stool DNA, which we will talk about, as well as a change in bowel habits. Next slide, please. So it's important to sort of risk stratify patients and decide, are you an average risk patient or are you at high risk of developing colon cancer? So what is an average risk? An average risk patient is someone who has no family history of colon cancer, there's no personal history of premalignant polyps or rectal bleeding, and there's no history of inflammatory bowel disease. Now, we know there are high-risk patients who do have a family history, and a small percentage of patients have a genetic predisposition for the development of cancer. These are the people who have Lynch syndrome, or what we call HNPCC, or hereditary non-polyposis colon rectal cancer syndromes. And it's important to understand that not every polyp is premalignant or at risk. All polyps, by definition, unless they have cancer in them, are benign, but there are certain polyps that are at risk for developing into cancer. So a hyperplastic polyp is benign, never becomes anything. An adenoma has a potential for becoming a malignancy as it gets bigger and undergoes genetic change. And there's a new lesion in the scene called the sessile serrated lesions, first described in 2003, felt initially to be benign, but then found to have malignant risk. So we talked about what are some of the things that increase your risk of developing colon cancer. And again, these are observational studies. We know cigarette smoking, excess body weight, too much alcohol ingestion, processed meat and red meat, low consumption fruits and vegetables, low fiber diet, low calcium, and an active lifestyle can all contribute to the development and increase your risk. Dr. Salwitz mentioned about the use of aspirin as a preventative. There may be some role for that, though it's not universally recommended at this time. It's important to note that in average risk patients, most guidelines recommend start screening at 50, and we'll talk about this a little bit more, though some guidelines suggest that African Americans may develop colorectal cancer at a much earlier time and have a more aggressive course. So screening should be started at age 45. In addition, there has been some recommendations by the American Cancer Society that given the recent rise in colorectal cancer in younger adults, that screening should start at 45 for everyone. Most societies have not adopted this recommendation yet, and certainly insurance companies have been reluctant to cover people at this early age. Next slide, please. So what are the options for screening for colorectal cancer? So these are the listed options right now. I'll talk about one more in a moment. The old standard, the guaiac fecal occult blood test, it's where you take a smear of the stool, it gets put on a card, it gets put a reagent on it, and if it turns positive, it suggests that there's something there. It's sort of fallen out of favor by most societies, with the exception of the National Comprehensive Cancer Network. The test that had a lot of false negatives and false positives. So we've sort of gone away from that. The new test on the block is what we call the FIT test, or fecal immunochemical test. It's actually an antibody test. It has a much better result. It has a sensitivity of 75 and specificity of 94%. And if you're going to do this test for it to work well, it needs to be done every year. Now, for those of you who hate epidemiology and statistics, which includes me, myself, and a lot of my friends, I just want to briefly discuss what sensitivity and specificity, so we're all on the same page. So sensitivity basically means I know my patient has the disease. What is the likelihood that this test will show that they have it? That's important when you're doing a test. So if the test is very sensitive, highly sensitive, and it's negative, you can be certain that the patient doesn't have the disease. Now, specificity, on the other hand, is I know my patient doesn't have the disease. What is the chance that the test will show my patient doesn't have it? So if this test is highly specific, and if it's positive, then you can be certain that the patient has the disease. So we look at these numbers to help decide how good these tests we use. So the new kid on the block is the FIT DNA, the multi-target stool DNA test, what people refer to as the Cologuard. You can't avoid seeing it advertised on TV. Tremendous marketing job. Its sensitivity and specificity is better than the FIT test. It's about 92% sensitivity with the specificity of 86%. But it's recommended to be done every 3 years. Now, it's important to understand that if you have a positive FIT or a positive Cologuard, then you need to have a colonoscopy. So the colonoscopy, there's two types of colonoscopies. This is the optical versus what we call the CT colography. In fact, the CT colography, a lot of people haven't been doing. The Radiology Society recommended it not be done during the COVID outbreak because it would cause a lot of downtime to their machines and it needed to be cleaned. So it's sort of fallen out of favor a little bit, but we'll see what happens. But it's important to note that the colonoscopy is the only therapeutic option. So in other words, it detects and it potentially removes premalignant lesions. And if you've had a negative colonoscopy with a good prep, you're supposed to have it every 10 years. Next slide, please. So, I saw this cartoon and it amazed me because I say this all the time. So this was on a Blue Cross Blue Shield questionnaire profile. Have you had a colonoscopy within the last 10 years? And they described the tube inserted into the rectum to check the entire large intestine. And the possible answers were yes, no, and don't know. And you read at the bottom, it says, seriously, how could you not know this had happened to you? And I say to my patients, I said, really, somebody actually put a tube up the rectum and you don't remember who that was? I would have gotten name, security number, license plate, the whole bit before I let somebody do that. So believe it or not, it still happens. Next slide. So here's something I hear all the time. I had a colonoscopy and I was told everything was fine. Well, what does that mean? I mean, I think it's important to understand that no test is perfect. Colonoscopy does have a miss rate, averages about 22% when you look at all the studies across the board. And there's something called an adenoma detection rate, which is an important quality measure that is worth pursuing. you should have an adenoma detection rate or an ADR of about 25%. So what is an adenoma detection rate? That's the percent of patients greater than age 50 who undergo a first-time screening colonoscopy, it means they're asymptomatic, who have one or more conventional adenomas detected and removed. And they're saying that the rate should be 30% or greater in men and 20% or greater in women, because it's really sometimes more difficult to perform a good colonoscopy on the female patients, has to do with anatomy, etc. So these numbers have been slowly bumping up as years have progressed. They initially started under 20%. And it's important to understand that for every 1% increase in ADR adenoma detection rate, there is a 3% decrease in colorectal cancer incidence. That means cases of colon cancer that are found. And more importantly, a 5% decrease in mortality. So these numbers are of significance. So people ask, what's the risk of a screening colonoscopy? Well, obviously there's the risk of sedation, has to do with comorbidities, other medical issues. In routine colonoscopy, there's a risk of perforation of about 4 in 10,000. There's a risk of bleeding in about 8 to 10,000. And obviously this risks increase if polyps are removed. You can see bleeding in up to 2.6 over 1,000 of patients in these things, in these patients, if you try to remove a polyp. Now, you know, again, as we talked about, there's increase associated with other medical issues such as heart, lung, kidney problems, associated medications. Everybody's taking anticoagulations and blood thinners. As well, as you get older, you can see problems as well. Next slide, please. So here's another question I have asked to me all the time. So when should I stop having screening colonoscopies or regular colonoscopies? And you know, the first question I ask is, what's the indication? Are you having a screening procedure? Are you having a surveillance procedure? Are you having a diagnostic procedure? Is there a family history? Can I delay having my procedure because of the pandemic? This is a new question, and the answer is, again, depends upon what the indications are. I think recent studies have shown that if you have something delayed for 3 to 6 months, probably not detrimental to your health, but after the 6-month interval, there may be some issues. How is your prior history with the procedure? What did they find? How did you tolerate it? Was it technically difficult? Were you uncomfortable after the procedure? Family history, we talked about comorbidities, your quality of life, and risk versus benefits. The bottom line is there needs to be a shared decision making. So the conversation with the doctor and the physician have to be made. And the question I ask the patient all the time is, how long do you plan on living? And I think that's an important piece of information. In other words, if the patient says to me, listen, I'm 85 years old and every day is a blessing, and I'd rather not know what's going on, I understand that, and we may defer. We may perform benign neglect. If on the other hand, I have a patient who says, I'm 80 years old, I want to live to 100, we try to be a little bit more aggressive with those patients. So next slide. So there are multiple guidelines and recommendations, and the problem is when you have multiple guidelines and recommendations, obviously there's not one definitive answer. We have the guidelines from the American Cancer Society, which were last updated in 2018. The National Comprehensive Cancer Network was also 2018. The United States Preventative Service Task Force was in 2016. And then our societies got together, the American College of Gastro, the American Society of Gastrointestinal Endoscopy, and the American Gastroenterology Association in 2017 published the United States Multi-Society Task Force on Colorectal Cancer Screening. And that's what we're going to talk about briefly. And they're going to be updating it actually this year. And they actually were able to recommend different tiers. In other words, tier 1 is the preferred, tier 2 is second down the line, tier 3. So tier 1 was the colonoscopy every 10 years or an annual fecal immunohistochemical testing. Tier 2 was the CT colonography every 5 years, the FIT DNA every 3 years, and they still threw in the flexible sigmoid scope every 5 to 10 years. That's the short tube, looks at the last 25 inches of the colon. And tier 3 was the capsule colonoscopy, which is not readily available, and truth is not covered for screening. The only indication really is if you've had a failed colonoscopy or there's a contraindication to doing a colonoscopy and the patient is symptomatic. Next slide. So this is the last slide. I apologize for it being very busy, but I did want to throw it out on there just to sort of show you the different recommendations for the screening. And if you go to the left side of the slide, you'll see the guidelines and the years. The middle is the age, and then the screening methods. And you can sort of see the American Cancer Society talks about starting earlier at 45. And they actually said when you get to 85, discourage screening. Between the ages of 75 to 85, it should be individualized. There's the Canadian, which we won't talk about. The MSTF, they start at age 50. They then talk about 45 if African American, 75 if life expectancy they talk about is less than 10 years. And then they say maybe not do anything. And then they actually said have a conversation if you're 85 and above. And then you could sort of see what their recommendations are. So the bottom line is one glove does not fit everybody. There's different variations of the theme. A lot of what's driven has to do with insurance coverage, has to do with your comfort with undergoing procedures, and has to also do with the risk benefits. So all these things should be discussed with your physician. Thank you for your time.
Thanks very much, Ira. I really appreciate it. Next slide, please. So assuming you've had a colonoscopy and assuming that it finds colon cancer, we move on to the next step. So the next step in this process is what's referred to as staging. Now, when patients ask, what's my stage, they frequently don't quite understand the question they're asking. They think they're asking the question, what's my prognosis? How long do I have to live? But stage for the physician, for the surgeon, has actually two other distinct meanings and may not relate to prognosis at all. The average person with stage 4 testicular cancer is cured. People die of stage 1 lung cancer all the time. Stage to a physician means two things. First of all, it means where is the cancer and where is it not? And in terms of colon cancer, is it just in the inside lining of the colon? Has it invaded partially through the wall? Has it invaded through the wall? Is it spread to the local lymph nodes? Or, God forbid, has it spread somewhere else? Has it possibly spread to to the liver or something else? And that's one thing that stage means to the physician, surgeon. And then the other thing it means is how much surgery do you need? And there's a pretty, and that is to say, frequently as the tumors get higher stage, you need more complicated surgery. Although that's a little less true with colon cancer because stages 1, 2, 3 end up with very similar local surgeries. But so that's staging. Part of staging is also is blood tests, tumor markers tests, the CEA blood test, which can pick up colon cancer, CAT scans, which can look where the cancer is or is not. Usually we don't use PET scan in this disease at this time. And then there may be family history genetics going on. And then the other question, the next question is, what's the general medical condition of the patient? What is their tolerance going to be for possible surgery or other treatments? What else is going on? How do they have to be, how do they have to stabilize? As a general rule, age is, we don't try to make age an independent statement. You don't say that a 50-year-old gets this and an 80-year-old gets this. We may take into account that the 50-year-old has multiple other medical problems and the 80-year-old just finished running the marathon. And age itself is independent. Can this all be done during COVID? Can you do surgery during COVID? I think I'm going to let that question go to our next speaker, Dr. Nell Maloney Patel. Dr. Patel.
Thank you, Jim. I appreciate the opportunity to be here today, and thank you also to the East Brunswick Library for putting this on. I think it's really important and obviously timely. As a surgeon, a lot of what I do is more visual, and so I have a bunch of pictures that I'm going to show, and some of them are anatomical, so I just want to kind of warn the audience that I'm going to be showing you body parts. This, I think, is, Dr. Merkel did an excellent job describing the advantages of the different screening approaches and the importance of it. I like this picture because it shows you a normal colon on the side and then what a polyp looks like and then what that becomes as it develops into a cancer. And so as Dr. Merkel pointed out, many times these polyps can be removed earlier with a colonoscopy that doesn't involve surgery at all. And in fact, even in some early cancers, we're able to do advanced techniques in order to remove the cancer without having to do a formal operation on the colon. Many times, however, when patients come to me, the mass in the colon looks more like the mass on the end, and these really are not amenable to more local therapies. And so that's when surgery starts to come into play. You can go to the next slide. So this is my world. This is the colon sitting among a background of the rest of the body. Many people ask me why I decided to do colon and rectal surgery, and I did it for lots of different reasons. But one is that I actually find this to be a very beautiful organ. And also one of the reasons that I like colon cancer specifically is because of what Dr. Salwitz was saying, is that it's actually a very curable disease. The way that I look at the colon when I'm thinking about cancers has a lot to do with both the blood supply. And so there you're looking at the blood vessels coming off of the main blood vessel in the body. And you can see how the colon kind of is all connected through an arcade of blood vessels, allowing us to remove a portion of the colon and leaving the rest intact to continue to function normally. In cancer surgery, we're interested both in taking out the cancer, and then as Dr. Salwitz alluded to, we also want to take out a percentage of or a portion of the lymph nodes. So within the fatty tissue around the colon, and here you can see this fatty tissue around the blood vessels and around the colon, that's called the mesentery. And within the mesentery are lymph nodes, and one of the important steps in terms of figuring out staging has a lot to do with whether or not any of those lymph nodes also have cancer. Much like Dr. Merkel was describing for the colonoscopy, there are standards that we want to get when we do a resection. So we want to make sure that we get the mass out entirely, that we have what's called a margin around the mass. So we have a distance away from the mass in order to make sure that there hasn't been any spread. And then finally, we want to take out usually at least 12 lymph nodes. This means that we've had a complete resection, and taking out the adequate sample or the adequate part of the colon is important both for prognostic as well as diagnostic reasons. So diagnostic to give us the stage, to let us know where the cancer is in the body, as Dr. Salwitz alluded to. And then secondly, to let us know prognostically that if we've gotten out every cell that started to spread, there may be some benefit to that. Next slide. One of the real pleasures of doing colorectal surgery is that we've had evolution in time from being a major open operation that you see up in the left upper quadrant to much smaller operations and with a better recovery. Lots of people that come to see me about surgery are concerned about how it's going to impact their life and how it's going to change their bowel function, and also whether or not they'll have to have a bag afterwards. Usually, when people have cancer in the colon, they do not need to have a bag. Occasionally, if the cancer is way down low in the rectum, or if they've had to have treatment that Dr. Salwitz was talking about previously, like radiation and chemotherapy, there may be a role for sometimes a temporary bag. But again, in most cases, people don't need to have a bag after surgery. We do still consider this to be a significant abdominal operation. And so after an operation, people do spend time in the hospital recovering. And that has played into how we've thought about things in the COVID era. In general, though, most of my patients are in the hospital about 2 days when I'm able to do a minimally invasive surgery. And so really, there's a nice pathway forward in terms of how people recover from this operation. You can go to the next slide. Since this talk was really focused on the care of cancer patients during COVID, I wanted to go over how our societies responded to it. There were actually a number of different position statements put out by surgical organizations that were coordinated. So the American College of Surgery, the Colon and Rectal Society, as well as the Society of Surgical Oncology came together to put forward guidelines moving forward. What they considered in this were two things. One was the cancer itself, and so how the cancer itself would progress. And the second was the conditions around the pandemic. So what resources were available within hospitals. Very specifically to colon cancer, we did have some leeway there. So as Dr. Merkel alluded to, in colon cancer, we probably have a little bit more of a window to allow patients who are asymptomatic with colon cancers to have their surgery at a time when it's most safe for the hospital. It was still important, however, for patients who needed to be treated urgently to get treated. And so sometimes colon cancers can cause problems that I'll go into in a minute. But to not operate urgently if our hospital was going to be overwhelmed otherwise by the COVID disease. We can go to the next slide. So this is an example of phase one. Phase one was both in the ramping up and in the ramping down of the COVID epidemic. In phase 1, it was felt that hospitals had still available resources, whether it was operating time, places that were safe for the patients to recover afterwards that were COVID-free, or even just resources related to masks, ventilators, and operative equipment so that patients could be taken care of safely. In phase 1, we do cases that are done as soon as it's feasible. So we try to do the operations within a few weeks of identifying the problem. These included cases that were nearly obstructing colon cancers or nearly obstructing rectal cancers so that the patient wouldn't have additional complications related to their disease. Cancers where patients were requiring blood transfusions. So if they were losing blood from the tumor, which is a common thing to happen, if they were requiring transfusions related to that blood loss, that would be a reason to remove the tumor in this setting. Asymptomatic colon cancers, again, were able to be operated on. We felt that cancer was something that now that we have resources available and in the very beginning of the pandemic were important to take care of. And then rectal cancers that had no response to therapy, so that wouldn't benefit necessarily from time. Cancers with concerns about local perforation or sepsis, so again, advanced things, and then early stage rectal cancers where the radiation and chemotherapy that Dr. Salwitz alluded to earlier were not as appropriate. Next slide. These were diagnoses that felt could be deferred for 3 months. So polyps where there may have been a couple of cancer cells within a polyp that hadn't actually yet invaded into the colon wall. Prophylactic indications, so operations where you knew that somebody had either the FAP or the HMPCC and they were considering prophylactic surgery. Large benign or asymptomatic polyps, small carcinoids, and small rectal carcinoids. Next slide. The other thing that was very nice about the way that the recommendations were put together was that it allowed some leeway and some ideas collaboratively about how we could treat different issues in a multidisciplinary and a multifactorial way so that we weren't always pushed to surgery when there were opportunities either for chemotherapy, for neoadjuvant chemo and radiation therapy, or where there were opportunities such as in rectal cancer when you've had treatment to wait beyond the typical window because we knew that it wouldn't impact long-term survival or long-term opportunities for operation. Next slide. Yeah, so for me, the surgical part has been something in evolution. During the COVID crisis, I certainly have had to take care of some of the patients that presented in the way that we described with either perforation or with transfusion, but we've also really been able to collaborate both with our gastroenterologists and our oncologists and medical and radiation oncologists to make sure that we're optimizing every opportunity for the patients that they're getting the best care. Thanks, Jim.
Thanks very much, Nell. Really appreciate it. It's a lot there for people to digest, but really well done. So now we're at the point. So someone who's been diagnosed with colon cancer has had the colon cancer removed, and then there's several questions that now occur at this point. First, and the most important one is, do they need any more therapy at this moment in time? And the therapy we're talking about this moment in time would be chemotherapy. Now, if you've removed the cancer and it seems to be gone, and the scans are fine, the blood tests are fine, the pathology says that you got it all, if you will, why might one do chemotherapy? And the idea is that there maybe be microscopic cancer that may be hidden somewhere, either in a lymph node that you didn't remove or somewhere else in the body, that might eventually come back. And the idea of using chemotherapy at this point, what has been referred to as adjuvant chemotherapy, a much better word would have been insurance. The idea is that chemotherapy then would go and find those cancer cells, even if you don't know that they're there, and get rid of that, and therefore cure a patient that might otherwise have cancer come back eventually. So the challenge at this moment is, how do you decide who doesn't or doesn't get chemotherapy? Because you're looking at a patient who now looks healthy. And the way that decision has been made over time, is looking at risk factors. And that is, what things have you found during the staging process, which includes what you discovered at surgery, that says this cancer seems to be gone, but we're more concerned. And so there are certain things that make you more concerned. For example, if there were lymph nodes involved, even though they were removed, maybe there's a tiny bit somewhere else that didn't get caught by a lymph node. If the tumor itself had gone through the wall of the bowel, and even though that's been now removed, is it more likely to be contaminated? Sometimes if the cancer is of a higher grade, a more bizarre, strange, aggressive cancer, you may then want to think that person's at a higher risk. And so you may very well, at that situation, want to use chemotherapy, even though the person appears healthy, because the research is absolutely clear. There's a large number of individuals in this situation that chemotherapy, can make a tremendous difference about, and it can decrease the risk of cancer coming back in those high-risk patients, by some 30%. Now, again, this balances out how old is the patient. In this case, what is their expected survival? You might not do this in a 90-year-old, even if they're in very good health, or other medical issues going on, and the particular risk of the chemotherapy. Chemotherapy, this is fairly standard at this point. It's pretty much get a very similar sort of treatment no matter what, because it's been routine. It's basically every 2 weeks for about 6 months is the standard therapy. There's some mild variation. Obviously, there's always research going on. But that's what you would want to do in this situation. Chemotherapy like this is well tolerated, and the main side effect you still have a terrible time dealing with is fatigue. It's just some days you feel really punk. We're pretty good about nausea and vomiting, not perfect. You may have hair loss. If it does, it comes back. You may get drops in blood counts. And there is always a concern with some of these medicines about like neuropathies, and people who go through this treatment here constantly. You have any tingling? Do you have any tingling? You're trying to prevent that from happening. But the idea is that you're going to clean out the rest of the body. Now, we're talking at this point about patients who've had surgery that don't appear to have any cancer left behind, and they're maybe what this role is. Now, one area we haven't really touched on, though, is a little bit of a different disease because of its location. And that is what Dr. Maloney Patel was talking about, was the primary approach to primary colon cancer. But we haven't talked about rectal cancer, which, while it's part of the colon, actually is approached often a little bit differently. And Josh Pepek will fill us in. Josh?
Jim, thank you. And again, I want to thank the East Brunswick Public Library for putting on this talk, and thanks to all of you for the opportunity to present today. As Dr. Salwitz mentioned, I will be speaking on rectal cancer and considerations for treatment and how radiation fits into that. Rectal cancer is unique among other cancers throughout the colon, and that's primarily due to location and some of the data that supports the use of radiation, either preoperatively or postoperatively in treatment. Next slide. So again, you saw a slide previously from Dr. Maloney Patel in a little more detail on the anatomy of the colon and the rectum. And again, I think it's just important to highlight where the rectum sits throughout the rest of the colon. Next slide. So the rectum is in the lower part of the large intestine between the sigmoid colon and the anus. It is typically around 15 centimeters in length, although that can vary from patient to patient. But the delineation between the rectum and the colon is largely anatomical. There is a membrane that lines the abdomen and the abdominal organs, which is referred to the peritoneum. As the peritoneum goes into the pelvis, this reflection delineates the colon from the rectum. And the reason that this is important, in part, is how this helps to drive treatment considerations for colon and rectal cancer, because we do treat them both in a fundamentally different way. Next slide. So as mentioned, rectal cancer is treated differently. Now, typically with patients who are diagnosed with a cancer in the colon, surgery is usually the first-line therapy, although as mentioned previously, that preoperative neoadjuvant chemotherapy can be considered as an option in the COVID era. But usually, for most comers, as Dr. Maloney Patel mentioned, surgery is going to be the initial therapy for colon cancer. Now, for rectal cancer, surgeries could be first. And this question is largely determined by the cancer stage. However, for patients who have a more advanced cancer, either chemotherapy alone or chemotherapy and radiation followed by surgery is the typical approach. Typically, there is no role for radiation therapy in the treatment of colon cancers, other than very select circumstances where the cancer is very advanced and fixed, or in some studies, cases of perforation. But generally, there would be no role for radiation for colon cancers. So rectal cancer, again, largely depends on the stage. So rectal cancer staging is determined not only by a CAT scan, but also by either a pelvic MRI or an endoscopic ultrasound, which helps to determine the depth of tumor invasion through the rectal wall, and also helps us determine if there are any lymph nodes in the fatty areas that encompass or surround the rectum itself. So for early stage rectal cancers, typically usually very superficial lesions, upfront surgery could be considered. However, and more commonly for more advanced cancers, either chemotherapy or chemotherapy and radiation followed by surgery is the expected approach. Next slide. So as for colon cancer, surgery remains the foundation for curative treatment for rectal adenocarcinomas at this time. There's some research looking at, either chemotherapy and radiation alone for rectal cancers, but again, surgery remains the foundation for curative treatment. Now, smaller, more superficial cancers can be removed by a local excision. But most, the challenge with those is that it does not remove the lymph nodes that are in the fatty area called the mesorectum around those tumors. So we can't assess those lymph nodes pathologically. For more deeply invasive tumors, they require more extensive surgery, referred to as a total mesorectal excision, or TME. Now, the two main types of surgeries are either one called a low anterior resection, which removes the rectum as well as the fatty area of the mesorectum around it, and an abdominal perineal resection. Now, the difference between those two is the low anterior resection, the sphincter, the anal sphincter, is maintained. There is usually a bag placed temporarily for patients, and then reversed at a later date, assuming that anal sphincter function is good. Abdominal perineal resections are for cancers in the rectum, which are usually lower in the rectum, closer to the anus, where the sphincter cannot be preserved. And that usually would lead to a permanent bag being placed. And largely that just determines based on tumor location, sphincter function, and response to chemotherapy and or radiation. Next slide. So as far as radiation for rectal cancer, preoperative radiation for rectal cancer is part of the standard of care approach for more locally advanced rectal tumors. These tumors are normally tumors that are either have lymph nodes that are positive on those staging studies that we discussed, or tumors that are more advanced. It says T3 here. That just means a tumor invasion through the muscle wall of the rectum. The reason that radiation or preoperative therapy, that is part of the standard of care approach, is that there have been studies that have looked at the role of preoperative therapy versus postoperative treatment. And there really appears to be a real benefit for evaluating and treating patients preoperatively for rectal cancer. For one, we see better tumor downstaging, meaning the tumor shrinks and makes it a little more amenable to surgery. And in some cases, we can improve the chances of performing a surgery that preserves the anal sphincter. Other studies have shown that preoperative therapy reduces the chance of cancer recurring in the pelvis after surgery, and some of the side effects associated with preoperative therapy, particularly radiation, are reduced in the long term with preoperative treatment as opposed to postoperative therapy, which was the long-held standard, many years ago. Radiation therapy can also be used in the metastatic setting as well, either for palliation, either due to bleeding or pain, and could be considered as well prior to surgery in select cases where surgery could still be considered an option for patients who still have metastatic disease. And that is a decision, obviously, that is done in a multidisciplinary setting between the surgeon, medical oncologist, and radiation oncology as well. Okay, next slide. So what about radiation and rectal cancer during the pandemic? I think important to stress that radiation therapy can still be given. It can be given safely and effectively during the pandemic. At least at our centers, there are very rigorous screening protocols that are in place to ensure that patients aren't expressing any symptoms, limiting throughput throughout the centers for patients who are getting treatment. And although pelvic radiation may cause some drop in some of the blood counts, it shouldn't have a large impact on the immune system as we proceed through treatment. Now, typically, for many patients, the typical course of radiation therapy is a daily treatment, Monday through Friday, over about 5.5 weeks. Usually that is together with chemotherapy that we coordinate with Dr. Salwitz, giving that chemotherapy at the same time. However, the American Society of Radiation Oncology and other societies mentioned have looked at other treatment protocols for radiation that can be done during the pandemic. There is good data that shows that a shorter course of radiation over 5 fractions, just a week, where we give a higher dose of radiation each day, can be considered in select cases. Important to note that although we standardly do our treatment over 5.5 weeks here in the US, this is still a well-tolerated treatment with a good track record. It is a regimen that is commonly used in Europe, where we give radiation therapy alone. This is not a treatment where we give chemotherapy together with it. Because we are doing fewer treatments, the benefit for patients is that there is less chance of exposure to COVID by coming in and out every day. And also potentially minimizing some of the toxicity that could be associated with giving chemotherapy at the same time. Of note, there still usually is a role for chemotherapy for patients, but can either be given before surgery or postoperatively in the adjuvant setting. Next. And that's all I have. Again, thank you all for your time. I appreciate it.
Josh, thank you very much. I really appreciate it. Really good, really well. We do have some questions, but just as the last part, unfortunately, this is a disease which can spread. When it spreads, it is often can be fatal. There have been a lot of advances in treatment and approach to this disease when it's advanced. A lot of chemotherapies, both oral and IV, are available, which can keep this under control. There are medications called anti-angiogenesis, just more IVs that can stop the microscopic blood vessels that feed these cancers. So there are drugs that target the genetic growth factors that drive these. But one thing we've learned in patients that this disease, is not curable is that a combined approach is often wise. Sometimes you're using chemotherapy and, as what Josh was saying, with radiation for certain problems. Sometimes you're doing chemotherapy, but you're also doing surgery, and in some cases that can even be curable. I mean, the surgical approach is someone with a single colon cancer metastasis spread to the liver, you may be able to remove the original tumor and surgically remove the one in the liver and then keep people in control for a long time. I just saw by telemedicine a patient the other day that she had a single nodule in her lung, and that was like 15 years ago. And we removed the original tumor, we removed the lung tumor, and she had chemotherapy, and she's been fine. But this is still a disease. We have a lot to learn, and in order to keep people living the longest, curing the most. But we have come a long way, and there's a lot we can do. Is there another slide? No. So before we go to questions, basically the take homes are, that this is a disease that, by lifestyle we can decrease, by colonoscopy, we can detect, and when it comes back, and we have a lot of treatments, a lot of alternatives. I do suggest you have a close relationship with your GI doc in order to keep on top of this. Surgery is the key curative therapy for this disease, with key radiation and chemotherapy being, working around that. And that even with people with advanced disease, there is a lot we can do. So we have some questions here, which I'm going to kind of bounce them off some of my colleagues here, as we go through. So one question, which I'll just take, is that the question was, how serious is so-called signet ring colon cancer? One thing we haven't talked about today at all is that cancers have a microscopic structure. We talk about cancers being adenocarcinoma, which means gland forming at a microscopic level, which is what most colon cancers are. But there are other types of colon cancer, that can occur that are not the average adenocarcinoma. And one of those is what's called a signet ring. It's a description of what it looks like under the microscope. Signet ring is a fairly rare colon cancer. It's less than 1% of colon cancers. And unfortunately, it is extraordinarily aggressive and tends to grow very quickly. If it is caught early, like a regular colon and adenocarcinoma cancer, it can have a fairly high cure rate, but unfortunately, its tendency is, because it's so aggressive, is to be caught late, and therefore it can be much more difficult to cure. Until recently, we had pretty limited luck with chemotherapy against that disease. That is improving, but it's still this is a disease for which can be very, very, very challenging. So it's a tough disease. A couple other questions. So Ira, I'll throw a question over to you. I think it has to do with people thinking about symptoms and confusing symptoms. So the question was, and how can you tell the difference between having irritable bowel symptoms and colon cancer? But I guess it goes back to the question, what symptoms are there symptoms of colon cancer that people can expect, to have that would warn them? All right.
Well, I think it's important to understand we're talking about two separate issues here. We're talking about going for screening colonoscopy, which by definition means you're asymptomatic, and then you're going for a diagnostic colonoscopy. So you could have an early cancer and be asymptomatic. You could present with anemia. That is an indication that you're bleeding from the tumor. You could present with a change in bowel habits. Typically, you see left-sided colon cancers causing change in bowel habits sooner than the right side, because the left side, the stool is more firm, so you may become more constipated if the tumor is on the left, as opposed to the right side of the colon, where the tumor is, where the stool is usually liquid, and it's usually a late finding. You can see abdominal pain. Usually that's an ominous sign, because it suggests that the tumor has spread. So you don't always need to have symptoms to have colon cancer. And unfortunately, sometimes by the time you do have symptoms when you have colon cancer, it's an advanced disease.
Thanks, Ira. Now, a question for you. You were obviously mentioning minimally invasive surgery. One individual wondered, is there still a role for minimally invasive surgery if the cancer has spread beyond, the abdomen? Say you had a lung met, but still had the colon cancer present in the abdomen. Is still a role for surgery or for minimally invasive surgery in that situation?
Yeah, I think the important thing with these kinds of situations where we have advanced disease is the multidisciplinary approach. And so where I work at Rutgers, we make sure that we have not just the medical oncologist, the radiation oncologist, but also our surgical oncologists that operate on the liver, working with us as the colorectal surgeons to come up with or actually our thoracic surgeons if it's a pulmonary mass, working together to come up with it. Really, the opportunity to operate on metastatic disease and colon cancer has improved over time. And so you are correct, Jim, that it used to be that if you just had one nodule in the liver, that was considered something that we could operate on, but that's extended into, there's much more flexibility there in terms of the different opportunities that we have for operating on those lesions with the goal of cure, which is one of, again, the reasons that I like my field, is that we have opportunities even in more advanced disease. In terms of minimally invasive approaches, that has a lot to do with just the patient characteristics. And so, yes, definitely minimally invasive approaches are possible and encouraged because the recovery can be much less. Sometimes it might not make as much sense if we have to do a large liver resection and a colon resection at the same time. It may just be more straightforward for the patient, less time in the operating room to do an open approach. But again, those are very individualized decisions. Certainly for something like if they're going to get a lung resection, a minimally invasive approach is very appropriate.
Thanks, Nell. So Josh, I'm going to give you an entire a whole new topic to talk about here, which was mentioned, and it's important actually. The question came up of what about anal cancer, which is a anatomically related but different disease with different approach. Do you want to just run briefly through, Josh, anal cancer and how that's handled?
Sure. I mentioned in the talk that surgery really is the foundation for a rectal adenocarcinoma. And I guess the focus, the key on that is the adenocarcinoma part. Anal cancer is treated differently compared to cancers of the colon or rectum, where typically surgery does not have a role up front, in part because most of the anal cancers that are diagnosed are a different cancer histology. Most of them are squamous cell carcinomas as opposed to an adenocarcinoma that we would commonly see in the colon or rectum. There are protocols that have been done over many years using a combination of chemotherapy and radiation for anal cancers that have shown very high rates of cure for patients who have localized anal cancer. Radiation typically is over about 5.5 to 6 weeks, given together with usually 2 different types of chemotherapy. So, right, it's a totally different treatment paradigm compared to cancers of the colon or rectum.
Thanks very, very much.
Jim, can I comment about that? As the surgeon, many times we are, or actually probably you also, Ira, as the gastroenterologist, we're seeing patients presenting with the anal cancers where it's been misdiagnosed as a hemorrhoid. And so one thing that I would advocate is that if you have an anorectal complaint, you've got bleeding, you've got pain, you've got a bump that doesn't go away, don't just think that this is a hemorrhoid, even if you've had a colonoscopy in the recent past. So that usually needs some evaluation, and if it's a bump that doesn't go away, some kind of a biopsy. And absolutely, I agree with Dr. Pepek that the treatment should be radiation because of the ability to preserve sphincter function, not having to have a permanent bag, and again, the histology of the cancer. But many times we find this disease later because of the fact that it's misidentified early on.
Thanks, Nell. One question, and actually I alluded to it, but I kind of missed it in my comment, came up, and that is, what about the use of pure immunotherapy, the so-called checkpoint inhibitors in this disease? And it turns out that in certain genetic, because of recent approvals, in the presence of certain genetic targets, microsatellite instability in these cancers, that there is a growing role, still pretty early, for checkpoint inhibitors in this disease, in addition to chemotherapy, angiogenesis, et cetera. So there actually may be a role. Ira, going back to you, two quick questions. One, one question is, my doctor has never asked me to have a fit test. Should I? And secondly, as long as I got you, what about colonic marking as a part of monitoring patients going forward?
So they say the best screening test is the test that you do. So if you've never had any screening test and it's a choice between doing nothing and doing a fit test, then by all means do the fit test, understanding that you have to do it every year for it to be valuable. A one-time fit test and then never do it again is worthless. Let me also make a comment and let me dispel a misconception out there. If you are involved in a colorectal cancer screening program, that means you go to your gastroenterologist, you're scoped every 10 years if appropriate, every 5 years, whatever it is. Please tell your interns when they want to do a fit test, I don't need it. If you're involved in a screening program or a surveillance program, there is no reason to do a non-invasive test to see if there's any blood or you're at risk, because all you're going to do is confound the issue. Now, because of the insurance and because everybody's checking off on their computer, I did the screening test, doctors are ordering these tests inappropriately. And it's not their fault. The education hasn't been out there. It behooves the patient to say to their physician, I have a gastroenterologist. I'm involved in a screening protocol. I'm up to date on my screening. I don't need a non-invasive test. That's number one. Number two, when it comes to the marking, I think the marking is important in only two real areas. One, if you find a colon cancer and you would say to the patient, you need to have surgery, and it's in a location that may be difficult to find at the time of surgery, you're giving your surgeon an opportunity to find it easier. So you take an inert tattoo material that's specifically formulated to be used in the colon, and you inject it in a certain area so that when the surgeon says, okay, where's the tumor, on the left side, the right side, the middle of the colon, there's a tattoo mark there. The other place where you might want to use a tattoo is if you had a difficult polyp to remove and you've taken off the polyp, whether it's in a piecemeal fashion or a portion of it may have been left there to come back and remove it in another setting. At least this way you can identify where the polyp is. At this stage of our recommendations, there's no reason anyone should go to surgery for a benign polyp unless they fail to have a colonoscopy removal. There are doctors out there who specialize in removing difficult polyps. Sometimes you may have to localize a polyp with a tattoo and then refer to one of these super sub specialists.
Thanks, Ira, very much. And then I guess one more question. The question was the association of thyroid cancer with colon cancer. So by far, most thyroid cancers are not related to colon cancer or any other cancer. But Dr. Merkel earlier commented on a genetic syndrome, familial adiposis polyposis, FAP syndrome, which is associated with more than 100 polyps in the colon. That is associated with a somewhat increased risk of papillary, one of the types, thyroid cancer. It's also associated with increased stomach cancer, pancreatic cancer, et cetera. But most thyroid cancer is not related to colon cancer and vice versa. So, Kathy, at this point, I don't see any more questions. So I'd like to thank everyone from taking the time to join us today. I hope this was of help. Obviously, if there are further questions, et cetera, please don't hesitate to reach out, obviously, to myself through our CCA, Dr. Merkel in East Brunswick, Maloney Patel at the medical school, or Josh Pepek at Princeton Radiation Oncology. We are here to serve you, and stay safe.
Thank you, Dr. Merkel, Dr. Maloney Patel, Dr. Pepek, and Dr. Salwitz for taking the time to talk to us and answer our questions. As I mentioned at the beginning of this program, this talk is being recorded. The link to the recording will be emailed to the registrants. It will be uploaded to the library's YouTube channel at ebpl.org/YouTube. The next topic in this Lunch and Learn series will be blood cancers on June 5th. The presenters will be Dr. Craig Lampert and Dr. Philip Pankari. Thank you for joining us today. Have a great day and stay safe.